Assalamu alaikum and good day. Today we are going to look at neoplasms of respiratory system. At the end of this lecture, students should be able to discuss the epidemiology and pathogenesis of lung tumors, list the precursor lesions of lung tumors, classify lung cancer, describe the gross morphology and histological features of each major classification, explain the clinical features of lung cancer, and describe briefly carcinoid tumor, mesothelioma, and metastatic cancer to the lung. Lung cancer is currently the most frequently diagnosed major cancer in the world. It is the most common cause of cancer mortality worldwide, and there is enough statistical and clinical evidence to show a positive relationship between tobacco smoking and lung cancer. Males are affected more than females, and lung cancer in Malaysia is one of the most common cancers, accounting for approximately 10% of all cancers. Nearly 90% of lung cancer patients in Malaysia are diagnosed with stage 3 or stage 4 disease. 90 to 95% of the lung cancers are carcinomas, 5% are bronchial carcinoids, and 2 to 5% are mesenchymal and other miscellaneous neoplasms. So you can see here, there are either primary bronchogenic or primary pleural tumors or primary neuroendocrine. And there are also a lot of secondary or metastatic tumors that can occur in the lung. Now we look at the etiology and pathogenesis of the neoplasm of the lung. We will look into tobacco smoking, industrial hazards, air pollution, some molecular genetics, and precursor lesions of neoplasm of the lung. There is a linear correlation between the frequency of lung cancer and pack years of cigarette smoking. 80% of lung carcinomas occur in active smokers or those who stopped recently. Compared with non-smokers, average smokers of cigarettes have a 10-fold greater risk of developing lung cancer. Heavy smokers of 40 cigarettes a day for several years have a 60-fold greater risk, and women are more susceptible to carcinogens in tobacco than men. Even second-hand smoke or environmental tobacco smoke contains numerous human carcinogens for which there is no safe level of exposure. Tobacco increases risk of all major types of lung cancer, and the strongest association is with squamous cell carcinoma, followed by small cell lung carcinoma, and the least one is adenocarcinoma. Certain industrial exposures increase the risk of developing lung cancer. High dose of ionizing radiation increase the incidence of lung cancer among survivors of Hiroshima and Nagasaki. Uranium, which is weakly radioactive, also increase the risk for lung cancer. Non-smoking uranium miners have 4 times higher risk for lung cancer, and smoking miners have 10 times higher risk. Asbestos is a tumor initiator and tumor promoter. So asbestos and smoking can increase the risk of lung cancer by 55-fold. Lung cancer is the most frequent malignancy in people exposed to asbestos. This is a list of occupational agents and exposure circumstances that are classified as carcinogenic to humans with the lung as target organ. This list was compiled by International Agency for Research on Cancer. As you can see, it contains a lot of agents, mixture of circumstance, and it also listed down the main industry and use. It's uncertain whether air pollution by itself increases the risk of lung cancer, but it is likely that it adds the risk to those who smoke or are exposed to secondhand smoke. Chronic exposure to particulates in polluted air may cause lung irritation, inflammation, and repair. And this chronic inflammation and repair may increase the risk of a variety of cancers. Radon is a radioactive gas that has been linked to increased lung cancer in minors exposed to relatively high concentrations. Low-level exposure to radon in well-insulated homes in areas with naturally high level of radon in the soil may also increase the incidence of lung cancer. Smoking-related carcinomas of the lung arise by a stepwise accumulation of oncogenic driver mutations that result in the neoplastic transformation of the pulmonary epithelial cells. Exposure to tobacco, industrial hazard, and air pollution will cause genetic alteration in the lung cells, which lead to neoplastic phenotype. As there are estimated 10 to 20 genetic mutations that have occurred by the time the tumor is clinically apparent. The major histologic subtypes of lung cancer each have distinctive molecular features. Adenocarcinoma is associated with tobacco smoking, but less so than other histologic subtypes. It is the most common subtype in never smokers. About one-third of adenocarcinomas have oncogenic gain-of-function mutation involving components of growth factor receptor signaling pathways. This include gain-of-function mutations in genes encoding several different receptor tyrosine kinase, such as EGFR, ALK, ROS1, MET, and RET. Squamous cell carcinoma is highly associated with exposure to tobacco smoke. Most tumors have mutations in TP53. P53 protein overexpression is an early event. 10 to 50% of squamous dysplasia and 60 to 90% of squamous cell carcinoma in situ have P53 protein overexpression. CDKN2A tumor suppressor gene mutation and amplification of FGFR1 is seen in many of the tumor. Small cell carcinoma is virtually always smoking related and has the highest mutational burden among lung cancers. There is almost universal inactivation of both TP53 and RBG. There is loss of chromosome 3p in nearly all of these tumors. The World Health Organization estimates that 25% of lung cancer worldwide occurs in never smokers. These cancers occur more commonly in women, and most are adenocarcinomas, often with targetable mutations or co-mutations. Cancers in non-smokers are more likely to have EGFR mutations and almost never has KRAS mutations. TP53 mutations are not uncommon, but occur less frequently than in smoking-related cancers. Now we look at the 4 types of precursor lesions that may give rise to tumors of the lung. First is squamous dysplasia and carcinoma in situ that may progress to develop squamous cell carcinoma. Second and third is atypical adenomatous hyperplasia and adenocarcinoma in situ that may progress to adenocarcinoma, and diffuse idiopathic pulmonary neuroendocrine cell hyperplasia that may progress to carcinoid tumor. Note that not all of these lesions will progress to invasion and malignancy in all cases. As we've seen before, lung tumors are divided into primary and secondary. And under primary, we classify them into bronchogenic, pleural, and neuroendocrine. Under bronchogenic, that is about 95% of the lung tumors. There are squamous cell carcinoma, which accounts for 20% of cases, adenocarcinoma, which accounts for 50% of cases, large cell carcinoma, 2% of cases, and small cell carcinoma, about 15% of cases. The incidence of adenocarcinoma have risen, and one possible reason is due to increase in women smoker, but that does not explain why there are more adenocarcinoma. Another possible factor for this is the cigarette type. They are filter tip and lower tar and nicotine content. This causes smokers to inhale more deeply, and that exposes the peripheral airways to carcinogens. This area is prone for adenocarcinoma. It is also divided into small cell carcinoma and non-small cell carcinoma. Small cell carcinoma almost always metastasize, and it has high initial response to chemotherapy. Non-small cell carcinoma less often metastasize, and they have less response to chemotherapy. Squamous cell carcinoma and small cell carcinoma have the strongest relationship to smoking.